We come to the last session of this meeting, and that's a very interesting case discussion session. Heart failure with reduced ejection fraction with LVEF improvement, post-treatment with ARNI. I invite Dr. Darshan Jhala. This is a Novartis-sponsored session. Sir, please, it's all yours.
Yeah, thank you, Dr. Milin, Dr. Gupta, and it's first time I'm having a privilege of being the last speaker with such a large audience around. And Dr. Ponde reminded me of two things. One was 2001 Space Odyssey, where the HAL computer takes over from the humans. And that is what was the dark side of AI was. He starts by playing chess with the astronauts and then takes over control of the rocket and then creates a disaster. So that was what. And the second thing I was reminded was of Isaac Asimov's laws of robotics, which says that the first law of robotics says that no robot can take over from its creator. So these are two things. That's just apart from that. Well, we will start with the last presentation here. This has been an interesting phenomenon which I have personally observed, and fortunately we have some answers. 5 years back, this was a discussion which used to happen every time. We had, when these ARNIs, actually it started off with standard drugs like ACE inhibitors and ARBs, that we used to have occasional patients who would improve completely. And then the question was, patient would ask you, what do you want us to do? I remember a patient coming to me for follow-up of echoes, 30% EF, slowly, progressively increasing, becoming normal. Patient wanted to stop the medicines, and that time I had no answer. I did stop the medicines, and then I realized what had happened afterwards. So then talking to colleagues, we realized that this is a problem and we should have some answers. Fortunately, we have some answers now. So this is a theoretical case. A patient with HFrEF, raised NT-proBNP, and a restricted 6-minute walk test, and patient was initiated on the standard therapies. And he recently visited again. His EF from 38% improved to significantly 43%. NT-proBNP dropped, and the 6-minute hall walk test improved. Patient says, I can do my daily work now much better, without much difficulty. What do you want me to do with it? It's not that I can't afford the medicines, but I don't like to take medicines. They have side effects. So what do you answer to them? So should this GDMT be changed? Should it be descaled like we do for post-angioplasty patients? We go from ticagrelor to clopidogrel. Is it the way that we should behave? Now that the patient has stabilized and EF has improved, what do we do? So first thing is that this is a big myth which we have to understand. There is nothing like a stabilized heart failure. It is stabilized or it is static at that point of time when we are seeing the patient. What we are seeing is, let me say, is the phenotype of the heart failure. The molecular things inside, we don't know what is going on. So many times we have to realize that HFrEF is a progressive disorder, and what we have done is treated the underlying molecular abnormalities to the best of our abilities, and at the moment we have contained them, but what is going on inside is still going on. Barring a few things, like for example an acute phase of a myocarditis, for example. Now these are things which probably will resolve completely, but this is not the run-of-the-mill patients that we are going to see. We are going to see either established cardiomyopathies or ischemic cardiomyopathies, which are progressive diseases. And that is why we have to realize that this is a distinct entity, an improved ejection fraction. So the myth is that patient becomes clinically stable. The reality is that the underlying structural and molecular abnormalities which drive the disease progression are still operating. They have not been eliminated. They have been contained, and that is the basis for our future course of action in mind. So what happens when you discontinue GDMT, and what happens to clinical outcomes in a HFrEF patient who has improved? So discontinuation of GDMT increases the risk of mortality in HFrEF patients. Graph clearly tells you that if you continue GDMT, if you discontinue it, there is a 35 increase in risk of mortality on those patients who discontinued it. There is a 40% increase in 30-day readmissions. So we all know readmissions are a big thing with HFrEF. The lesser the readmissions and the more delayed is the readmission, the better is the prognosis. So this is clear data which tells you that when you discontinue GDMT, there is increased rate of readmissions. All-cause mortality goes up, and depending on what you have discontinued, there is a 3, 4 or almost 2%, 3% chance depending on which drug you have discontinued. So all drugs are important. No point in discontinuing one or the other. Especially when sacubitril valsartan was withdrawn, there is a significant deterioration in terms of mortality, morbidity, and this is there even at 12 months also. So if you continue sac-val for 12 months versus only 6 months, there is a significant difference in mortality and morbidity. As objective indices, the end-diastolic volume increases. And if you continue it, it returns to baseline. So this is the proof of the pudding. This is a very bad way of saying it. Their patient is on sacubitril valsartan. This X is his EDV. You discontinue it, his EDV goes up. You restart it, it comes back. And this was a recent study which was done, recently published, I think in ESC probably, which actually was a very, I would say, a semi-unethical study, where they studied patients who had discontinued their therapy, and they allowed them to be discontinued, and they kept watching them, and they found not only deterioration in their symptoms, but definite deterioration in terms of echocardiographic parameters. So it's a clear proof, and when they were restarted, the whole thing came back to what it was. NYHA class and symptoms definitely worsen when the ARNI is stopped. Now we come to this particular, so we knew that when you discontinue patients, they deteriorate. But many times these patients are perceived to be in NYHA class 2, which we don't give too much of importance. Like this patient said, I am able to do my day-to-day activities. So he is technically in class 2. So these are technically perceived as mild patients. So is that really so? Is the NYHA class 2 different from NYHA class 3 in terms of continuation of medical treatment or not? So because this is perceived as a stable disease and it's perceived as a low risk. And because the patient has a concern about taking drugs for a longer time, it spoils my kidneys, and such are the perceptions which go around. So the patient, when he reaches this NYHA 2, including the physician, has a tendency to either descale or stop. So what happens to these? NYHA class 2 patients are not low risk. They have an increased risk of mortality, and this is was shown in the Paradigm HF study that significant percentage of them die at 3 or 4 years. So this is not, it is just a stage of the disease. It's not a stable stage, and it is not a low risk stage. So in a nutshell, initiation and continuation of GDMT keeps the HFrEF patients alive and live longer. There is less hospitalization, less mortality, and increased functional capacity. And this is the ESC guideline, which says continue GDMT, start it and continue it, do not stop it or descale it. So GDMT is a foundation of heart failure care, and GDMT with the highest expected benefit should be prioritized. So coming to that, are we actually doing this? Even after listening to this, are we actually doing it? Unfortunately, we are using drugs in suboptimal doses. We are still attuned to the idea that when a certain level of improvement occurs, there is no need to upscale the therapy. What we forget is that we have to go back on RCT data and realize that we have to reach the RCT doses, and those are the only ones which have been proven to be of benefit. So when you start GDMT, try to approach the reach the guideline directed doses, and that is what gives you the maximum benefit. So 200 is the recommended dose BD of an ARNI. Try to reach it, and our inertia is the one that prevents us from reaching it. I think 80 to 85% of patients we can definitely reach the maximal doses without a problem. Even after this, we tend to discontinue. So I can't emphasize enough that reach the proper dose and continue with the proper dose unless there are some pressing circumstances. Like, for example, patient gets diarrhea or gets vomiting or something. For a short while, you might discontinue these protective medications, but then restart them as soon as possible. Now we come to the most sensitive part. Are all ARNIs the same? Well, obviously, this is a sponsored lecture. So the answer, yeah, but apart from that, there is a problem with the supramolecular complexes. Each of them, companies may not be following the same manufacturing process, and the ultimate drugs may be the same, but the combination probably is also important, and that is what that means. We are encouraged to use a similar the combination which is very similar to the originator, and so that is, I think, we should probably try to aim. And in conclusion, HFrEF, stable HFrEF is a misnomer. After GDMT initiation, discontinuation should not be done, and this is our duty to see that we spread this message. And it is clearly that once GDMT is continued, the results in survival are much better versus either descaling it or stopping it. Thank you.
Thank you very much, Dr. Darshan, for putting the perspective of using ARNI in patients and not discontinuing the ARNI once the patient has improved, because continuation of ARNI in such patients also beneficial in long run. So that's the, I think, clear-cut message from your talk. So thank you once again for your talk. I think
session doesn't have questions, but quick comment, only one comment, sir.
One small question, one small clarification I want. We have always been criticized, rightly criticized, that we do not build up the dose to the maximally used in the randomized control trial. Now, if you have a patient whom you have treated, he is on 50 milligram of ARNI, 25 milligram of beta blocker, and his ejection fraction has improved from 30 to 60%. He is stable, no symptoms. Anti-proBNP is normal. Should we escalate doses there, or we continue with the same dose?
Yeah,
that answer is not clear anywhere in any data.
It's not clear, but then, see, I will take a parallel from some other trial which is not related to this. When you are adjusting doses of NOACs, why do you use a particular dose? Do you have any parameter which you are monitoring? No. Means when you start Eliquis, you start at 5 milligrams BD. Rivaroxaban 20 milligrams OD. Why are you doing? Are you measuring PTT, INR, anything? No. You are relying on data which comes from large RCTs. So the answer to this is also the same. If you have to believe the RCT data, you go by the RCT data and go and upscale it. I mean, that's precisely what I'm trying to say. Though there is some data which says that if in a given patient, if you are not able to upscale it for some reason, whatever, hypotension, those patients also benefit on smaller doses, but the benefit probably is best with the recommended doses.
Thank you very much, Darshan. And now I think it's a sort of every place we have got some signature things. So Academy of Cardiology symposiums or conferences have this signature closer by concluding remarks by Dr. Satyavan Sharma, where he puts the summary of all the talks in 10 minutes. So anybody who has not attended the whole conference may get the, I think, all the gist of the conference in next 10 minutes. So over to Dr. Satyavan Sharma, sir.